Okay, next up we have Ashley Merkel presenting Emory's approach to donation cardiac death. Let's hear it for Ashley.
All right, I'm a little tall. Hey everyone, thanks for having me today. I am the lead organ procurement perfusionist down at Emory, or I guess that would be up at Emory, and have had the opportunity to work with our team on all of the mechanical support projects going on right now in the transplant world. I'm going to say this so that you all can hold me accountable. This will be the last time I give this talk, so if you've already heard it, I'm sorry, but we're going to freshen it up for the next time. I have no disclosures. So today, first, we're going to start with a quick history of transplants, talk about the Dead Donor Rule and the Uniform Declaration of Death Act. Then we'll go into DBD, which is what we all commonly know as what we're used to with heart transplants. Then we'll dive into DCD, donation after circulatory death, and review some of Emory's cases. Okay, so to understand how we got to where we are, we must go back to where it all began. In 1967, Christian Barnard performed the first heart transplant. At this time, there was no guidelines on defining death. So as it turns out, it was actually a DCD heart. However, during this procurement, there was some ethical and moral concerns raised. So they took a step back and decided not to do DCD procurements. As a result of this, the Dead Donor Rule was put into place. This rule said that the patient must not be killed by organ retrieval, or organ retrieval itself cannot cause death. Afterwards, they continued to define and redefine the terms to death. The Uniform Determination of Death Act was created, and it says that an individual who has sustained is dead when they have sustained either irreversible cessation of circulatory and respiratory functions or irreversible cessation of all functions of the entire brain, including the brain stem. So if you take a look at these two definitions, you can see how one might be DBD, donation after brain death, and one would be DCD, donation after cardiac death. For a while, we forgot there was two components to the definition, which led us to where we are today. So DBD, what is donation after brain death? I'm going to go through this a little quicker than I normally would for the sake of time, but DBD heart transplants are characterized by three main criteria. The first is that the donor must be in a coma. The second is that they must have an absence of brainstem reflexes. And the third is that they must fail the apnea test. When I created this presentation originally, I realized as perfusionists, we often don't get to see a lot of this and what goes into classifying donors. So I took the time and went through all of the different steps for how to get a donor to check the boxes and become a donor. For the sake of the presentation today, I'm actually going to skip a couple of these, but as you can see, there's a coma scale that judges how deep the coma is and whether or not there might be brain response. Similarly, there's a brainstem assessment that the donor must go through that takes into account each major brainstem nerve and tests them for a response. And then lastly is the apnea test. This is a test performed where they adjust the ventilator to therapeutic settings, disconnect, bag the patient, pull a gas, and see what happens to the CO2. If the CO2 rises, that's considered failing the apnea test, and they are eligible to become a donor. So DBD organ procurement, what does this look like? So this is a controlled environment. The donor remains intubated and on ventilator support throughout the surgery. Organs are harvested in a sequential order, with the heart being the first to go. Vasoactive infusions are needed to maintain stability, or can be used. The surgery lasts about 3 to 4 hours, and as we all learned, there's about a 4-hour ischemic time that's acceptable from cross-clamp at the donor center to reperfusion at the new center. So why does any of this matter? It seems that DBD heart transplants work well. We've been doing them for a while. So, what do they say? If it's not broken, don't fix it. Well, although it's not broken, there is some data that suggests maybe we need to find some more hearts. So you can see here in 2020 and 2021, there was about 3,700 hearts performed per year. According to the wait list by organs, there was about 3,437 patients waiting on a heart. However, if you look closely, last year alone, 5,000 individuals were added to the wait list. So that's a lot more than the 3,700 that we transplanted. And of those, unfortunately, 248 died waiting on a heart. And in addition, the median wait time for a heart was anywhere from 415 days to 72 days. And as we all know, many of our heart failure patients don't have that kind of time. So what do? We went back to the original definition of death and looked into how we could create more hearts. This is where we divided up the definition into DBD and DCD. The hope is that DCD hearts can grow the transplant volume by 30%. And recently, there's actually new data out there that suggests it may be closer to 50%. I know, speaking from Emory's experience, we're actually doing a lot more DCD hearts than we are DBD hearts. So DCD hearts, donation after circulatory death. What is this and how does it differ? So here's a chart going over the two, and if you look closely, I'm not going to read all of it, but you can see the injury remains the same for both. So DBD and DCD, severe brain injury from trauma, cerebral vascular accident, anoxic event, or other. If you go down one to meets criteria for brain death, yes or no. If it's yes, you continue as a DBD heart transplant and do everything we've just discussed. If the answer is no, some neurological reflex is still present, then the family will determine how they'd like to proceed with the care of their family member. If they choose to withdraw support, at that point, there would be a discussion as to whether or not they'd like the organs to be harvested. So what does a day look like on a DCD organ procurement? It's stressful. We'll start with that. So first is withdrawal of care. This is once the donor gets into the operating room and the donor is heparinized with 30,000 units, they turn off the ventilator, turn off all of the inotropic supports, and start what we call as the warm ischemic time. When you're going on a procurement, a DCD procurement, there's things to consider, which would be the hospital organ procurement policies. As you'll soon learn, time is of the essence on these runs, and depending on the location of extubation, you may choose to not go and take the heart because you only have about 30 minutes. And if they're extubating in pre-op or in the ICU, by the time they got down the hall to the OR, prepped, draped, your 30 minutes would be up. So important things. So as I just mentioned, there's a warm ischemic time, which is the time of extubation to the time the donor is pronounced as passed. However, the literature suggests that this actually is possibly a stable cardiorespiratory status. So for DCDs, they say that the functional warm ischemic time is when we start our 30-minute timer. So this is when the donor's blood pressure is less than 50, and that's systolic less than 50, or SAT less than 70. Now with circulation and how we're monitoring oxygen sats, we're not really going off of that as much as we used to. So really we just start the clock at 50 on the blood pressure. And this is the more accurate estimate of ischemic injury for these organs. So what do I mean when I say all of this? Why does timing matter? So as I mentioned, the literature has found that hearts have about 30 minutes of a warm ischemic time before, there's a bunch of responses and reactions that maybe would render the heart probably not viable. So if you work backwards to determine how long we have in the OR, you would start with your 30 minutes. It's going to take our surgeon 3 minutes to make sternotomy, cannulate the right atrium, drain off some blood, and give a liter of pledge. I'm sure you're all probably like, wait, what? 3 minutes? And then if you go back from there, there's a 5-minute no-touch period. So that's 22 minutes remaining that you have from a systolic blood pressure of 50 for the donor to pass. If they do not pass within the 22 minutes, we'll leave without taking the heart and go home sad. So this is just some literature that shows how they came up with the 30 minutes. All of the other organs have different timing limits. I think the lung is 60 or 90 minutes. The kidney, I think, is 120. But for the heart, we do a 30-minute warm ischemic period. So now, after declaration of death by the physician, a no-touch period ensues. This is a 3 to 5 minute period of no touching the donor that's at the discretion of the hospital. The purpose of this is out of respect for the family and the donor to ensure that they have in fact passed. During this time, some hospitals allow you to enter the room and prepare, and others require you to remain outside. Once the no-touch period is over, organ procurement may begin. And this is where I'll talk a little bit about the TransMedics OCS device, but also Emory has modified a lot of the techniques that they have used to make our own, and I'll talk about those as well. So at this point, once the donor has passed, the no-touch period's over, we are allowed to start. All harvesting teams are going against the clock because right now there's no perfusion to any of the organs, so it's just an ischemic phase. And within 2 to 3 minutes, as I mentioned, we'll make sternotomy, cannulate the right atrium, and drain off 1.5 liters of blood to be used in our circuit. So how do we do this? So here's our method, which is different than the TransMedics method. We just use a cell saver with a venous cannula and a drain line connected to about 75 to 100 millimeters of mercury for vacuum, and just drain it off that way. There's other methods out there using a bag reservoir and just using gravity, but we've found lightly applying suction helps us out a little bit more and speeds up the process. After we've drained off the blood, we'll hook up the drainage line directly to the Neptune, bypassing our cell saver, and this allows all of the other teams to drain and begin flushing and clamping their organs. We'll give 1 liter of del nido cardioplegia via a DLP pressure bag and gravity, and then apply the cross clamp. At this point, the surgeon will begin extracting the heart, and we step away to prime the circuit. While the surgeon continues preparing the heart, we give 800 milliliters of del nido via gravity drainage retrograde into the sinus, and then we'll go over and prime the machine and do a plethora of tests. So we'll perform baseline lactates and blood gases that we'll correct prior to the heart going on the device. We'll turn on a couple medications that I'll talk about a little bit more on the next slides. And then we will get ready for the heart to come over, and as he's walking over, or she, we will put our flow at around 1 liter, turn the temperature to 34, and turn our gas on. We'll also begin pacing the heart at 80 to 100 beats per minute and turn on a T4 infusion as well. The time from cross clamp to reanimation on the device is about 28 minutes. All right, so those medications I just talked about. We'll also run a couple of medications through the pump during the run, the first being the TransMedics maintenance solution. This is a solution that the company provides, and its main additive is adenosine. So this is used to regulate the dilatory effects of the heart. So if our pressure is rising on the device, this solution will automatically upregulate to give more delivered, more dilation. Also, we give an epi solution that is used not how we would normally see it used, which would be to regulate the blood pressure, but it is used for catecholamine responses from stress. And then lastly, we run a T4 hormone that is just a hormone replacement, possible usage increases organ donor availability, and that is not well studied yet, but we have not seen any negative effects. At this point, once the heart is on the device, we begin preservation and management. This includes visual inspection, which is performed regularly, and all we're looking for is a sluggish LV, RV, LV distension, things like that. We draw blood gases every 15 minutes until stable and then as needed, but at minimum 1 per hour. And then lactates every 15 to 30 minutes. So the lactate is the main determinant of whether or not we accept the organ. The goal here is to see a stable or downtrending lactate with your baseline used as a trend. So what I mean by that is if the lactate starts at 11 and stays at 11, that's okay. If it starts at 1 and goes up to 5, not okay. So, as long as you're stable, no matter where you start, that's okay. And then ideally, you'd like your arterial lactate to be a little bit higher than your venous. That just means your heart is happy in absorbing the lactate. Coronary flow is measured on the pump as well. The goal is about 700 to 800. We aim a little bit higher, closer to 750. And then the pressure goal is 75 to 80. And we found some of the younger hearts like a little bit of a higher pressure, so we go closer to 80 to 90 on those younger hearts. So here's a video of the device you can see. So there's the heart in the chamber. You can see all of the flow probes on there. I have a bunch of videos coming up as well. And here's the monitor that we use to see everything that I have. We'll go over on the next slide, and this kind of controls the medications, the gas, pretty much everything. You can see our surgeon loves to open this up and tell everyone to touch the heart, and then he says, "Oh my gosh, don't do that." So here's a picture of the monitor. You can see the pump flows about 1.16 in the blue right there. The coronary flow is 760, which is in the red. The temperature is about 34 degrees. Our heart rate is 80, and our pressure, which is on the top there in the lime green, I think says 69. And at the very bottom, you'll see the 3 little A, B, C MEO are the medications, and those are on preset rates. And so this is where we would just kind of control everything. You can see it's sitting in someone's lap in this picture, so we can kind of take it a little bit away from the pump and just manage it from the side. All right, so after initial stabilization period, which is about 1 hour, we evaluate the heart for the first time. As I mentioned, we're looking for a good visual exam, stable lactates, and an appropriate blood gas. If this all comes back good, we'll accept the heart, call the accepting surgeon, and tell them to go ahead and get started. If one of these items is not appropriate, we'll continue to monitor and reevaluate every 30 minutes to an hour. We continue this process until the heart is declined or accepted. One of the things that we've had to work through is the importance of having Wi-Fi on the airplanes, as you often haven't made a decision on your way home yet. So it's important to be able to communicate with your receiving surgeon if you just choose to accept or not. All right, once the heart's accepted and we return to the hospital, it remains on the device until the surgeon has removed the diseased heart and is ready to begin sewing in the new heart. At this point, we give another liter of Del Nido into the device while slowly cooling it down to 16 degrees. Once the heart is arrested, cold ischemic time begins again until reperfusion of heart and recipient. All right, so at Emory, what's our staff model? We have 4 surgeons trained on the device, 1 per procurement, and then 1 resident will go as well as the first assist. Originally, we started with a team of 3 perfusionists that were chosen based on their relationship with the main surgeon, communication, strategies, and abilities to multitask. However, the program has grown exponentially, so now we have a team of 9 to 10. To put that in perspective, our current team is 22, so about half the team goes on these runs. And we have a pretty strenuous training program. They go up to Transmedics for their training. We do a 2-day training at Emory going over dry runs, supplies, modifications, different things. And then they go on about 3 to 5 runs with someone that's already previously trained. And everyone seems to really enjoy these. One of the questions I get a lot during this presentation is, how do you staff this? It's pretty fun. Everyone enjoys it. We compensate the team well on these also. So overall, people try to go. Here's the plane we use for the most of the time. We created a holder for the device. It's pretty nice. And then here's just some outcomes. You can see we've definitely been further than we used to. We go up to New York, Pennsylvania, over to Wisconsin, and down to Texas. So it's allowed us to increase our pool exponentially. So how did we do? We've been on about 26 runs. I think now we're closer to 30. The average length of each run is about 12 to 24 hours. I just went on one last week. I don't know if any of you heard about the shooting that was going on in Atlanta. We were headed to that hospital and had to reroute and go back. So the run was about 28 hours. So it was a pretty good day, but it's okay. Everyone was safe, so we can't complain. Of the 26, we transplanted about 11, which is 42%. So the ones we didn't transplant was because they did not pass within the given 30 minutes or the heart was turned down. Average age of our recipients was 37 years old, and the average time on our device was 5 hours and 20 minutes, which, as we all know, that's more than 4 hours. So I think it's pretty cool that now we're able to go over that 4-hour threshold. I'll just go through a couple of these. I have a bunch, but as you can see here, our lactates, which is our main determinant of how the heart's doing, started at around 4.48 and went down to 3.25. You can see in that chart in the bottom left, all the values stay pretty level, which is what we wanted to see. And as you can tell, this heart looks, well, maybe. Did it turn? Well, it's sideways, but the heart looks pretty good. And then you can see here, the lactates went from 4.85 up to 6.88, which is not what we wanted to see. And as the numbers would lead us to believe, you can see from this heart, it was not a good heart. I don't know why they keep turning, but that's all right. If you turn your head sideways, you can see the heart. But if I don't play the video, you can see just from the picture the heart was pretty bad, and as you'd expect. We turned it down for rising lactates. Also, visual inspection was pretty terrible. One of the things that was interesting about this was that it was our shortest ischemic time of 12 minutes. So, you think a shorter ischemic time may be a better heart. That was not, in fact, the case. And then another case example, the lactates started 6.36, so a little bit higher. but went down to 3.92 nicely. And I'm not going to play the video, but you can see here, it looks pretty good just from your visual exam. Okay, I'm gonna try to play it. Nope. Those Macs. So I don't know why the videos aren't working. And then here's an echo. If you turn your heads sideways, you'll see the echo is great. And this was after implementation into the new recipient, and the EF was normal and the heart looked great. So our overall outcomes were that we had one patient come out on VA ECMO that would not wean from bypass. They were decannulated at about post-op day 4. All patients went home successfully. At 6 and 12 months, our survival was 100%. All of the EFs were greater than 55%. And I need to update this date, but as of today, all 8 out of 9 patients, or actually now it's, I think, 9 out of 11 patients, are all well and at home. One patient died of COVID last year. So current changes that we've made at Emory is that we now have expanded our both DCD and DBD region to the entire United States with the use of the device. And this would be for LVAD explants where it's going to take a little bit longer to get on bypass, flights that are over 2 hours, reduced sternotomies, and high-risk procedures. We're also working on creating our NRP program at Emory, which is normothermic regional perfusion. This is where the head vessels are tied off. You go on a modified ECMO, evaluate the heart at 30, 60, 75, and 90 minutes, and then place it in cold storage for transport or on OCS devices. The goal here is to minimize abdominal ischemic injury with this method, so you have happier teams. And then we're also hopefully by the spring or fall, I guess, participating in Ex Vivo's heart research study, which is using this device in the bottom left-hand corner. Hopefully we're hearing more about that once we get FDA approval in the US. And then Paragonix is this device in the middle, which is a free suspension device that holds the heart, and it's supposed to be a little bit better for a lot of reasons, but all things going on at Emory and the transplant world and things that we've been involved in and have really enjoyed getting to be a part of. Here's the FDA approval for using the device, same thing, and that's all I got. Thank you.